Well, welcome. Thank you for coming.
Thank you for having me.
So, Michael, if people didn't know you and
Yes.
they wanted to tune in and listen to everything we had to say, what would you tell them about yourself?
Um, how long have you got? No. In short, I'm a very proud Novocastrian who is now a orthopedic surgeon, subspecializing in mainly knee surgery, with a past background in rugby, I guess.
In rugby, when did you give up the rugby?
Uh, I'm a bit like Johnny Farnham, and I've had a few comeback tours. But generally, I quit professional rugby when I was 19 years of age, or 20, sorry. But then I had a few little cameos over the years, including most recently in 2022, playing for Maryville Carlton, my junior club, and that was pretty cool. Finished off with a premiership, and the guys in my team were as close in age to me as they were my son. So definitely the older head.
So you retired at the top.
I guess so, yeah. Retired a winner, yeah.
And am I correct in saying you were actually on the Aussie squad in the under 21s?
Yeah, age group wise, so played Australian schoolboys and Australian under 21s. And we had a little, for that Australian under 21s, we had a World Cup in France, which is a really cool experience. In our semi-final against France, who went on to win it, we had 5 Wallabies in the team, and I was the only one in the starting side who hadn't played for my state. So it was a pretty cool experience.
It's a big achievement.
Yeah.
It's a massive achievement.
It was good.
So with your role, I imagine with your role, you've got to deal with a lot of pressure and a lot of discipline. Do you think that sport kind of played into that a little bit growing up?
Yeah, I still use it. And I don't think when I was going through sport that we necessarily dealt with the mental side of sport as well as we could have. And I think that we've seen the problems associated with people post-retirement because they can't transition to normal life, so to speak. And the sporting world is a different realm. But I love looking at the top performers who are very poised and elegant and don't lose their cool. Unfortunately, during my rugby career, people would see me more as a Johnny McEnroe, but I would much rather be seen as a Djokovic or a Federer. And so you look at some of their techniques and mental strengths, and Dan Carter's books is great on that. I always look at ways that I can improve my preparation and my ability to cope with stress, as you said, when things don't go to plan. That conscious breathing, for example, is a big one that I try to utilize now before responding.
Nice. That's really good, actually. Really good. I had a feeling that would be the case with all your sports.
Yeah. Well, I think, we try to learn from all aspects of life in what we do. And sport is still a real passion of mine. And so I think it's only natural that I try to utilize that in my professional career to some way. And if I'm doing it in my own spare time anyway, and I love it, then it comes more naturally, I guess.
Nice. Now, am I right in saying this? You have over 50 peer-reviewed publications?
Yeah, just got 2 more yesterday. One in American Journal of Sports Medicine and another one in Journal of Experimental Orthopedics. So, yeah, I love my research because of that idea that, I'm a knee surgeon who's had my own knee injuries. So I was worried to begin with about doing knee surgery because I was worried that I was going to be too subjective in the way I treated my patients. And so the way I thought to better that was to be objectively the best I can be and use my own subjective experience to drive that. And I think research allows us to be objective about what we're doing. So if I'm constantly challenging what we're doing, evaluating what I'm doing to try to be better, I think that's the best way I can use my own subjective experience.
Yeah, and then using your own evidence that you see day to day as well.
Yeah, you got to be able to apply it to the patient. It's the real world's not a textbook, so to speak, but using the best available evidence that we can to influence the patient in front of you to get the best outcome.
Hmm. So with 50 peer-reviewed publications or more now, that takes a lot of dedication. So my question is, where was your why? What was the thing that triggered your career and doing what you do?
So when I was 12 years of age, I suffered my own meniscal injuries, and that kept me out of sport for a while. And then the way that they were treated at the time, which was probably best practice to a lot of the surgeons then, I then went on to suffer quite early arthritis, so to speak, in my knee. And when my football career finished up as a result of that, I thought if you can't beat them, join them. And so that's what drives a lot of it. You know, there's no doubt that when I see a young teenager with a meniscal tear and a promising career ahead of them, I think about my own subjective experience. And yeah, I am really personally invested to try to get the best outcome for them. And that's why, I'll do the after hours work, you know, the work in the dark, so to speak, because you don't get paid for that research work. It is a real passion project, but I think it makes me better in what I do day to day. So yeah, that's why I do it.
That's really good. I think most people in the health space, the good ones, the really high performers, they tend to always have their own story. And you're exactly right. Everybody gets into their own field, but they struggle at first, which you sound like you've cracked the code not to be too subjective straight away and see only yourself and all of that in them.
Yeah, and I don't like sharing those stories with patients because I don't want them to be biased by my own story or my own journey. I keep it very much about them, and because I don't want any of that, my own experience to influence their decision making. When I come to the end of the patient journey, when they're fully recovered, and they ask me about it or how I got into it, often then might share it, but it's only on very few occasions, and I think it would be wrong of me to tell the patients that, because then that influences their decision making process. So I want it to be objective and as evidence based as possible.
So with your knee now, can you give us an idea on where it's at and what you actually do to manage it?
Yeah, so it's pretty cool. One of the talks that I like to give to other health professionals is on young arthritis, and I start with a disclaimer of an x-ray of my own knee, and I'm like, what do you think of this knee? And without telling them that it's my own, and they say, oh, it looks pretty bad. Yeah, loss of joint space, a lot of osteophytes there. And then I say, yeah, it's my own knee. But I've learnt to manage my knee and understand what I can do with it and what I can't do with it. I'm doing a triathlon tomorrow. Running flares my knee up. So I have to be wary of how much running I do, but running's also great for my mental space. So I understand the balance of that. You know, I've got a little swim club I do each week, and I tell my patients with knee pain that the best exercise they can do is ride a bike. You know, so whether that's a stationary bike or out on the road, as long as they don't get hit by the car, I think it's one of the best things you can do for your knee. So I try to practice what I preach, and I'm a bit guilty of it at the moment, carrying a little bit too much weight around the midsection, but the best I can, maintaining a healthy diet and trying to keep that weight down. My knee notices it.
Cycling's really good, hey. It's and I'm guessing in your point of view, it's more you're going through those full ranges of motion, but without the impact that running kind of impedes on it.
Yeah, it's less, from what I'm aware, it's less impact than walking. You know, when you're sitting down, that motion is good for the joint and builds up the quadriceps in a low resistance environment.
Yep.
Yeah, so I think it's great, and there's evidence to back that as well.
Yeah.
Yeah.
So with your papers that you've done or your publications, is there any that you're particularly proud of?
Yes. Geez. One of the most recent ones was when I was on fellowship in France. There's a really good biomechanics laboratory called the Imperial College of London, and one of the most recognised engineers associated with orthopedic surgery is a Professor Andrew Amos. So I had the ability to travel to there a couple of times, and we did a biomechanical paper on the pressures behind the patellofemoral joint with where the trochlea or the floor or the groove that the patella sits relative to the femur. And so we proved for the first time biomechanically this concept of the anti-Mackay effect. And that just a couple of months ago got KSSTA's paper of the month, editor's choice. So that's a real highlight. And then my PhD, seminal work on that regarding patellar tendinopathy and trying to alter the biomechanics of it. I was very proud of that research because, when I first came up with the concept, 90% of people told me I was an idiot. So to then go and objectively prove it with data was really cool. A good moment in my career, so to speak.
That's awesome. So what's your biggest question now? What do you think's next?
It's still always evaluating what we're doing and trying to, I really like that idea of bringing it back down to basics. So that's why I like the biomechanical research, because I like to create pathology in the cadaveric knees, and then working out how that changes the kinematics and kinetics. That is the way that the joint moves and the forces upon it, and then how our surgical techniques or implants can alter that. So I've got a position at Macquarie University, and we're building a knee robot which attaches actuators to the muscles of the leg, and then we move the knee through a range of motion, and then the computer system works out how to activate those muscles to take the knee through that range of motion. So that's my next main research project. And at the University of Newcastle as well, we might be looking at setting up a ACL registry for Newcastle. And it's very early days, but it's looking very promising with the numbers that we'll be able to generate for a few of the local surgeons. We'll be able to really evaluate what we're doing, compare techniques, and work out what's best for our patients in that world as well.
Which on a local scale and a global scale, that could change a lot for outcomes with ACL reconstructions and everything going forward.
Yeah, it's very preliminary and very early stages, but to say I'm excited would be an understatement, because I think, I told you at the start, I'm very proud Novocastrian. I think Newcastle should be on the map, and just by a group of us coming together to be honest with our work and collect that data at no cost or inconvenience to the patient, I think it's going to be really powerful, both to the local community and, as you said, globally as well. Yeah, hopefully we can get there and make an impact.
And it brings all the local surgeons together a little bit, would you say?
It does, yeah. And those that are open-minded, it's really good when we learn more, when we share with one another, and we all individually will benefit from it, sharing ideas, and all of our patients will benefit as well.
Nice.
Yeah.
It's really good.
Yeah, I'm pretty excited.
You mentioned, you're doing a triathlon tomorrow.
Yes.
My ideology of surgeons is how incredibly busy you guys are.
Yes.
I suppose because when we hear or see you guys, it's the operating days.
Yes.
Can you give me a dive, like a deep dive into your week? How do you fit that kind of training in?
Yeah, I think the morning time is my time. So if I want to have some time for me, I've got to get up earlier. So I run, swim, or ride at least once or twice a week, and that's before everything starts, so to speak. Generally, I'll operate locally 2 days a week, and then I'll consult in the clinic 2 days a week, and then my other day is either on the Central Coast or down in Sydney at Macquarie University. And then when winter comes, I enjoy being down on the sideline and locally, I look after West Rugby League, but get involved when needed with the wildfires or whoever wants help, so to speak. So I figure if I'm down there watching it anyway,
Yeah, you
may
might
as
as
well
well.
take the medical bag. So
Absolutely.
it's really good. And then, but that's the beauty of being in Newcastle as well, is nowhere's necessarily too far, and being locally affords me to have that lifestyle where I can be subspecialized and niche in what I do, but I'm also able to have a great lifestyle as well. It is busy, but my dad really forced us to study hard and try to do well academically. And his advice was, if you ever want something done, you ask a busy person.
I like that.
Yeah.
That's a good motto.
Yeah.
If you had an 18-year-old standing in front of you, let's imagine that it's a union player that hasn't had knee injuries yet. Is there a key takeaway you could give them of this is how you look after your knee going forward for the life, especially in your sporting career?
I'd take it even a step back further than that. I see a lot of athletes sort of get burnt out and lose their love of the game. And, I look to other areas, and you look at Roger Federer, what he did and how he's able to sustain that for a long period of time. He really tried to stay in the moment. Steph Gilmore, she talks about, all these other surfers who were as good or better than her. They couldn't cope with the tour, so to speak. And the way that she dealt with it was that she considered home her suitcase, so to speak, so she just embraced herself in the tour and being present in the moment and getting everything out of it rather than thinking what she was missing out on. So as an 18-year-old with a rugby career ahead of them, I'd just say to always remember the reason why you play it, and that's the love of the game. And if you can hold on to that passion, then you'll train harder, you'll prepare yourself better, and you've got to find outlets for that to have a balanced life. Your identity shouldn't be who you are as a football player, but the characteristics that make you a good footballer can be what identifies you as a person, and focus on that and get fulfillment in other areas of life so that you can sustain that passion for a long period of time.
It's probably super important for that age too. How many people between like 16 and 20 do you see they'll play a sport their whole entire life? Not sure what happens at 16 or 17, but they just get that burnout in the sport and they just stop altogether. Sometimes they go through reluctantly, but other times they just lose it. But then you'll have some that still just day in, day out, keep the discipline. They've always got a smile on their face.
Yeah, well, everyone gets setbacks, and I think with the world, I don't want to sound too old, but with the world it is today, instant gratification's a big thing, and you get offered a contract when you're 14 now. You'll be in the night system, then all of a sudden they don't want you. What do you do next? Your identity as a person and everything was tied to that. There's a bit of ego with going back to local football or a level down. And so I think those are some of the things that might drive it. And that's why I think if the end goal is still the same reason why as an 8-year-old, or, I'm coaching the under-10s team for Merriweather, as a 9-year-old, the same reason why you play it then, the mateship, the camaraderie, the enjoyment, obviously, enjoying a bit of physical contact. If you still do it for those reasons, it doesn't matter what level you play. And if you have a long-term view, I think that you could hopefully get through some of those darker periods.
Yep. Is there any advice you see online, if you check online very often, that you think is kind of overrated towards knee health generally?
Well, I think there's a lot of stuff that isn't fact verified. I get everyone asking me about this injectable or that injectable, something from China, something from Germany. And my short answer is, if it was available, and it worked, it would be in me.
Yeah.
So I'd be the first one to want to offer it. So it's No, I think everyone out there is coming from a good place, but I think be wary of some of there still is snake oil salesmen's out there looking for that quick hit and over promising, under delivering.
A lot of bro culture.
Yeah, but if maybe that I might come back to that 18-year-old. I just thought of something that I thought of was that people often think of surgery as a fix it, so they'll have an injury and they'll just be like, oh, I'll just get it fixed. The more you can avoid obviously if you have something that's not going to heal and mend on its own, you need surgery, but the more you can optimize your body to prevent injury, because with each injury, our body never heals to 100%. Generally speaking, we heal by scar tissue.
Mm-hmm.
So you're going to come back impaired. So don't just think that you can battle your way through every injury. Having good core, good flexibility, good mobility, good strength, ensuring good recovery, you look after yourself, I think is really, really important.
Yep. So let's, I've had a few questions from a few people that we work with. Let's do ACLs as a broad topic.
Mm-hmm.
Does everyone need a reconstruction?
The short answer is no. The reason after an ACL injury, what you want to achieve is stability in your knee with day-to-day activities. So if you're 60 and you do your ACL, your functional demands are a lot lower. And so for day-to-day activities, you don't need an ACL. We need our ACL largely for pivoting-based activities. And so as a 20-year-old, that decision's a lot easier because you don't want to go through the next 40 years of your life having these instability episodes, and with each instability episode having a higher rate of meniscal injuries and the subsequent deleterious effects of that. The balancing act comes into the point where, that 40-year-old comes to you. I always trial non-operative measures first. I don't like the word conservative management.
Yep.
For the call it non-operative, because the prehab and the rehab from an ACL non-operatively is basically the same. And so I want them to try to achieve functional stability, work out if they can get back to what they want to do. And then if they have instability, then offer them a reconstruction. And generally they're much happier then with the result of the knee after surgery than if I just tried to sell them surgery to begin with.
Well, they'll also have a bit of a better base to work from, wouldn't they? Going through that rehab process, strengthening everything.
Yes, we know that if we do surgery too early on someone in a swollen, stiff knee, they're likely to end up with a swollen, stiff knee. So we want a knee to have minimal swelling to it, full range of motion, good muscle activation. And a little phrase I like to use with my patients is muscle has memory. So what you gain beforehand, it'll make your recovery quicker afterwards as well.
Is there a general timeline you like to give people now? Let's imagine 24-year-old semi-pro athlete. Is there a general timeline you usually give them of a 9 to 12 months or anything like that as a return to sport?
Return to sport, yeah. So everyone talks about that 9 to 12 month process. It's important to understand what an ACL reconstruction is. So we're taking a tendon from elsewhere, drilling tunnels in the bone, then plugging that tendon in, and then over that 9 to 12 months, but up to 24 months, it has to go through a process called ligamentization, where it changes from that tendon, essentially a dead tendon by the time it's plugged in, to a new neo ligament. And that doesn't happen overnight. So you want to balance that functional recovery. They've got to be able to do everything with ensuring that ligament ligamentization has occurred to the point where they're getting adequate strength. Because if they come back too early, the ligament's not strong enough, despite having good functional recovery, and they're at a higher chance of re-injury. But it's important to understand as well that not returning at 9 to 12 months isn't a failure. Yeah, the Scandinavian have these large registry-based studies, and they show that the average time for their soccer players or footballers was 18 months. So you just return when you're ready. You have to be psychologically ready and physically ready. That's the most important thing. But there does need to be a minimum time for the tendon that you've put in to become a ligament.
Yeah. And would you say that with that, we kind of already touched on it, that close to the most important aspect is up here, as long as they're 100% confident in it themselves,
Yeah,
that's a lot of it?
yeah, but there's also a false sense of up here as well with some young dumb males, but with the way that females are playing sports nowadays as well, and the way that they're athletically developed, I think sometimes they're young and dumb as well, and so they do need to objectively pass their return to sport criteria as well, or little battery.
Yeah,
Yeah, to
definitely.
ensure that they've got the ability to land and change direction safely with minimal stress on the ACL.
Yeah. Now, you mentioned the graft generally coming from a tendon or tendon-like tissue. Can you go through the process on pretty much where the grafts are available from and why you would choose particular ones depending on the person?
Yep. So generally speaking, you can have an allograft or an autograft. There is also xenografts, which is from an animal, but they're largely experimental. But there's a surgeon in Australia who's looking at getting the kangaroo tendon as a xenograft available. But generally, an allograft is a donor tendon, and the beauty of a donor tendon is you don't get the harvest site morbidity. So with an autograft, if I take your hamstrings, you're going to get hamstring weakness and have some issues with hamstring strains. If I take your quadriceps tendon, you get quadriceps weakness for a certain period of time, and you can get some pain up in your quadriceps. If I take your patella tendon, you can have difficulty kneeling and a high rate of some anterior knee pain. So generally, I say wherever you take it from, you rob Peter to pay Paul. So the beauty of an allograft is you don't have those issues. So you have a much quicker recovery with less morbidity from your surgery. But in the really young population, it's been shown to have a higher incidence of re-rupture. So I don't like utilizing it for that reason in the young patients. But in that older group of patients that we talked about before, your risk of re-injury after an ACL at 40 years of age is very low. Your tendon quality as we get older also gets worse. So if we can use a donor tendon there to have a more reliable tendon and reduce that donor site morbidity, given that you have a low re-rupture rate, that's a great idea. But in a 20-year-old, I don't want that. It's more important for you to not have a revision,
Yeah.
Because with each revision, your chance of returning to sport at a higher level decreases.
Is there if you were a sprinting type athlete, so let's say a rugby player versus a jumping type athlete, like a basketball player, is there a preferred graft choice that you would normally go with?
Yeah, so back to that age of you want to reduce the donor site morbidity. So there is individual benefits to each graft, but I generally pick the graft based on what would cause more harm to the patient. So in a jumping-based athlete, if I take their quads or their patella tendon, that's going to impair their ability to jump more. So my preference is to take a hamstring tendon in that population. In a rugby playing population, I love the patella tendon because it's bone blocks at either end. It's got that ligamentization process is a bit quicker, and it's a stiffer, more reliable graft. But in someone that needs to kneel for their occupation, it's sort of a no-no. And so then where's the quadriceps? And so the quadriceps comes generally for me in someone who don't think a hamstring is the best option, but they don't want a patella tendon. And the judo athletes are a great synonym for that because they need to be on their knees and they need their hamstrings for grappling. So they're the athlete that I really like to do a quadriceps tendon in.
And in an ACL rehab, let's say post-surgery, in that first month, is there anything really vital?
Yeah, yeah, I think that it's important to understand what's happening at the biological level and what the construct that you've done can undertake. So if it's an ACL, which just an ACL, which it rarely is, an ACL is often has associated injuries, with injuries to your meniscus in particular. Then if it's just the ACL, the first 2 weeks I tell patients to focus on minimize the swelling in the knee, getting quadriceps reactivation and ensuring they have a straight leg. If you do not achieve a straight leg early after surgery, you have a higher chance of getting a cyclops lesion. And that's not something we can get back from, and you potentially need that debrided. But generally then, once they're comfortable, they've got good swelling control, good muscle activation, then the focus is on hypertrophy and neuromuscular control for that first 12 weeks while the graft takes at either end of the tunnels. Once it's taken at the tunnels, then we can generally introduce more explosive activities such as running and jumping, but they need to have that baseline foundation of strength to be able to do that before they progress. But then at that point, the actual graft in the middle is at its weakest. So it's starting to feel good, but it's really important they don't go back to pivoting related activities. And so then we work on developing correct landing techniques, getting back to running in a straight line, swerving, and then the cutting should come once they've got all that, and the graft is strong enough to be able to tolerate some load for it.
Yep. And I imagine the thing that you see go wrong would be going back to those kind of cutting and pivoting things that little bit too early.
Too early, or patients, come to me and they're like, yeah, doc, look, I'm already bending it back to 120 degrees, at week 2, but they're struggling to get it. They go to 5 or 10 degrees, and I tension everything pretty much in full extension, and so there's no reason biomechanically why they shouldn't be able to achieve full extension. It's just the knee prefers to be in a slightly flexed position when it's painful and swollen, and your quadriceps aren't working as well. So tell the patient, I don't care how high you can bend it at week 2. What I want is your quads turning on and getting it straight. So I think it's really important then to understand what you're trying to achieve, because you tick that box off, you got a straight leg early on, you can regain everything else and catch up with everything else. But if you've got a bent knee at 6 weeks, that's something which is really hard to get back. And it's going to affect your ability to run, jump, land, and generate loads.
Do you see any difference in rehab between an athlete as opposed to more general population?
Yeah, and I think that's been part of my journey as a surgeon, and that idea of what the evidence says is best versus what this patient will do well with in front of you, because there's other procedures such as a lateral extra-articular tenodesis, which we can add with each of those ACL grafts when it's appropriate to reduce the risk of re-injury. But that also adds an extra element of pain, stiffness, and swelling, particularly in that first 3 months. And Julian Feller, who's a very prominent ACL surgeon from down in Melbourne, he just published or presented his results related to the quadriceps tendon and adding that procedure and the patella tendon. There was significantly high rates of return to theatre for those things like cyclops and the inability to get the leg out straight. So, athletes, when it's their identity, they can tolerate some stiffness and they can push through that pain to regain full range of motion. But that extra pain and stiffness can be really debilitating to someone who's more of a recreational athlete. And one of the great sort of pseudonyms or analogies for that is the Scandinavian population. Data has shown us that if you have an MCL injury, they often heal really well with non-operative measures, but you often end up with a little bit of laxity. And laxity just means more play or movement in the joint, but that doesn't necessarily mean you feel unstable on it. But that extra laxity can put extra stress on your ACL. So what we know is in those that have these high-grade MCLs with an ACL as well, is that the patient experience, they'll prefer their knee or have a better feeling of it even though there'll be that little bit extra laxity with the non-operative management for the MCL. But generally speaking, there can be a higher rate of re-injury to the ACL. So that's where you've got to pick your approach for your patients. So in a higher level athlete with a high grade MCL, grade 3 that's opening in extension and 30 degrees, I'll be more likely to reconstruct both the ACL and the MCL at the same time and at an earlier time point, rather than treating the MCL non-operatively and then doing a delayed ACL reconstruction. But in someone who's more recreational, despite a little bit of play in the knee or laxity to that MCL, they'll prefer that than the stiffness and the pain that they'll have to try to get through and manage with both being reconstructed.
There you go. I didn't know that about the MCL. Completely off topic. Have you seen LeBron James' knees?
I haven't.
You haven't?
No, tell me about them.
They're incredibly bowed. And the man is 42 now, still playing in the NBA.
Yes.
Still ridiculous.
Yep.
And I'm honestly curious how much pain that man is in every single day of his life.
It's one of those things you look at most professional athletes, in particular soccer players, and they've done a German-based study where they followed young soccer players or footballers, if I say it correctly, and their bow-leggedness or varus increased as they aged. And it's whether it's that chicken or egg phenomenon, whether the varus or the bow-leggedness makes them more athletic to then do well at those sports, or whether it's the football and the single leg stance, which causes them to develop into more varus. But no, just to being out of alignment doesn't necessarily mean you'll be in pain. But once you start to get structural damage through that inside of the knee, if you are varus or bow-legged, it makes it hard for your body to recuperate or recover from that. And that's where I can come in with correcting the alignment to change the biomechanics through that part of the knee joint.
Yeah. Yeah, I see him at the end of every game, those huge bags of ice.
Yeah, but
massive.
You also watch soccer or football. You don't see that many knock-kneed people running around.
Point.
Yeah. So it's and I know some surgeons who won't touch someone's realignment even if they've got pathology on the medial compartment or the inside of the knee where the forces are higher as a result of that bow-leggedness, because they think that the varus is more important to them from a functional perspective. But so it's an interesting one. But yeah, chicken or the egg. But if you look closely at those legs, there's not many knock-kneed professional soccer players or athletes in general.
Don't mind me just recaffeinating a little bit. Have a drink if you like and go for it.
Yeah.
Yeah.
Is this where you get the this podcast is sponsored by?
I wish. I mean, they can if they want. Unfortunately, we pay for it at the moment. Yes, sponsored by Celsius. No, unfortunately, we pay for it at the moment, but you know.
Yeah.
Meniscus.
Oh, yeah.
For those at home who hear it all the time, but have absolutely no idea what it is, can you explain it in layman's terms for me?
Yeah, meniscus is a C-shaped structure between the tibia and the femur, which protects the articular cartilage. The articular cartilage covers the ends of your bone. You lose that. You start to get pain, stiffness, and swelling, which is arthritis. And the meniscus functions as a shock absorber to decrease that force through your articular cartilage.
Okay. So, yeah, the two bones that create your knee.
Yes.
Pretty much it's just the cushions in between.
Exactly.
Yeah, cool.
Better analogy.
Now, this is really hard because I know the answer to this is going to be all about context and pain and everything.
Yes.
When people do have meniscus tears, which are incredibly common, when do you surgically repair or trim versus non-operative about to say conservative, but not conservative, non-operative.
Yeah, so you come back to the question, the meniscus functions as a cushion, which protects the articular cartilage. You lose your medial meniscus as a generalization. Forces in that compartment go up by 100%. You lose your lateral meniscus as a generalization. Forces go up by 300%. So in a teenager who's got a meniscus tear, one which defunctions the meniscus, it's a pretty simple solution or it's a pretty simple answer for me that I want to repair that meniscus because I want to protect the long-term health of the knee.
Yep.
You go to someone that's 50 or 60, they're already in that age bracket where they're starting to develop arthritis. And often the meniscal tears in that population are more of a degenerative process rather than a acute and traumatic process. And there are specific incidences where I will still repair a meniscus. For example, a root tear in the older population. But as a generalization, no, I'm not repairing their meniscus because the rehab that they have to go through after I've repaired it, and then the subsequent success rate in that age group, the juice isn't worth it. Juice isn't worth the squeeze. So we treat them symptomatically. And it's really interesting. There's an orthopedic surgeon called Scott Dye who injected local anesthetic and then had an awake arthroscopy. And he went through and probed out all the different structures around the knee. And the meniscus itself is largely aneural, but where it attaches to the capsule or synovium is innervated. So what I really like to do in this population is to inject some local and corticosteroid at that meniscal capsular junction where the tear is to try to settle some of the inflammation. And then that I educate them normally about the degenerative disease process and try to get them to get back into low impact activities that we talked about before, strengthening the leg. Because once that inflammation's settled, they can often improve their function with non-operative measures to get back to a good lifestyle. And we know from higher level evidence as well, we call randomized controlled trials where we do sham surgery on someone and trim the meniscus, that we're not very good at getting rid of that dull ache that a lot of these patients present with. If an older patient is going to have surgery with me for the meniscus tear, it needs to be for what we call mechanical symptoms such as catching or locking as a simplification.
Yep.
Yeah.
Okay. Speaking of corticosteroids and stuff, have you dabbled in any of the other injections? So we're talking plasma, is it hyaluronic acid?
Oh, yeah. Synvisc, these sorts of things. Generally, there's not a lot of high-level evidence to support them.
Mm-hmm.
We can talk about leukocyte-rich versus leukocyte-poor, PRP. But if a patient really wants to try it, I tell them this, and then I refer them on to a sports physician or to have it injected with the radiologist. But I guess the main downside to it is just the cost, and so I just want them to be aware of that. But I try to get them on a bike.
Yeah, exactly. I mean, if you can avoid any form of intervention in a way, that's a good way if you can get around it.
Yeah, but unfortunately, there's no high level evidence to support a lot of those injectables. But as long as the patient's well informed and educated, happy for them to go ahead and try it.
Yep. Pain versus damage. Do you see a lot of people in your rooms that have pain come to you first, but objectively looking at their scans, everything's whistle clean?
Yeah, it goes both ways. I see people with a lot of pathology and not much pain, and then people with a lot of pain and not much pathology. And so the first instance, my job is when someone comes to me and I can't see much wrong, is to make sure that they've been sent to me with the correct diagnosis or correct imaging. One of the a common one is that you can often get referred pain from your hip down to your knee. So I had a patient come to me with recently with severe knee pain. He just had a small meniscus tear. And then, I examined his hip and that reproduced all his knee pain. Get an x-ray, got bone-on-bone arthritis in his hip, but he has a hard time believing me. So then you do a diagnostic and therapeutic local injection into that hip joint to show him that his pain goes away. 3 or 4 months later, he had a hip replacement with me and all his knee pain was gone. So he was very happy. But yes, often, despite other workups, we can't find that the pathology that they have doesn't necessarily reflect the severity of the pain, but I make sure the patient tries to feel heard and acknowledge their pain. But I also try to tell them that the interventions that I can offer aren't worth it, and they would often be left being dissatisfied with my treatment. We know that those patients with less severe arthritis who have a joint replacement have a higher rate of dissatisfaction. So I love the patient that comes to me with the x-ray with bone-on-bone arthritis and they've put up with it for 10 years. They've managed their knee well, but it's just gotten to the point where they can't manage it anymore. Those types of patients are generally very satisfied post-operatively.
Absolutely.
Yeah.
I can imagine that.
Yeah. So no, I try to inform the patients, show them what the disease process is, educate them on it, but also try to make them understand the limitations of surgery and tell them that objectively I'd like their disease to progress further before I intervene, because otherwise, I think they'd have a higher rate of dissatisfaction. The other portion to that is patients come to me, and they often say, I said, tell me about your knee. And they're like, my scan says I've got a meniscus tear, I've got, chondral lesion here, this and that. I'm like, no. We'll get to that, but I want you to tell me about how this is affecting you. Where's your pain? I don't have pain. Okay. Do you have instability? I don't have instability. You examine them. Their signs then don't generally reflect a lot of the scan results. And so you get to the end of the consult and you say, yes, you have some damage in your knee, but you don't have a lot of symptoms. And if you don't have symptoms, how can I make you better?
Yeah, we call that the scan trap at work.
Yeah, okay.
People will get their results and then they come in and the same thing. What's wrong with your shoulder? I've got this, and that.
Yes.
What's your pain, not what's your diagnosis?
Yes.
Show me what the pain is.
Yeah.
And a lot of the time it has nothing to do with the diagnosis.
No. There's a certain portion of the population who has pathology in each of their joints around their body just as a result of age.
Mm-hmm. So what is a common misconception people tend to have about surgeons in general?
I don't know, you might be able to tell me that better than myself, but I like, my patients say, I want you to fix me or thank you for fixing me. There's a quote, I dressed it, God healed it, is one of my favorite lines, because I don't fix patients. I just put things back into the right position or change some of the biomechanics so that the body can heal itself. And so, patients will come to me who often smoke. And I say, well, why should I? Hippocrates says, before you embark on healing someone, ask them if they're willing to give up what will stop them from healing. So if I'm going to put things in place, but you're going to do something which impairs your blood supply, which is how we heal, why should we go on that journey together? If you truly want to get better, you got to give up smoking. You got to give up your vaping.
Yeah.
So I guess that's I don't fix things, so to speak. I just put them back where they should be, or I dressed it, God healed it. I put it back in place, your body healed it.
Do you have a number of people that would come in and see you versus a number of people you actually end up operating on?
For example, with those, I don't have that data, obviously from a business model, it's more beneficial to have more patients having surgery for each one you see. But I think I just keep it patient focused and just trying to help people and get them better. And the rest of it takes care of itself. But I know, for example, with the the degenerative meniscus tears, I would operate on less than 1 in 10 of the patients that see me. I try to educate them.
Not worth it for them.
Well, I think we often make them worse, and I have made some people, you get rid of the mechanical symptoms, but they're like, yeah, now that dull ache's there worse. And that was part of the informed consent process. We trialed all the non-operative measures to begin with, but if I'm operating on someone, it needs to be in that degenerative meniscal pattern. It needs to be for those mechanically related symptoms, But yeah, I would operate on less than 1 in 10 that are sent to me.
Yep.
But I do get a lot of joy and utility out of helping them through that process where they're difficult and they've got an acute exacerbation of pain, educating them, and then starting those non-operative measures. And hopefully that does then start a therapeutic relationship whereby when the time comes in the future, they trust me to look after them surgically for the degenerative knee.
So with drumming up business, so to say, I've always wanted this from a surgeon's point of view. So for us, for example, we'll go out and chat to everybody, GPs, sporting clubs, all of that kind of stuff. Do you guys do quite a lot of that in the background that people don't see? Like, are you there building relationships with local GPs? I know that you're obviously at the sporting clubs a lot, so hence we send people to you that are always in the sporting field.
That's been my best way of getting known is by trying to participate. Newcastle's 2 degrees of separation. So, often my referrals have come from someone saying, oh, yeah, you should go see Michael, so to speak. And I really enjoy being involved in the community at different levels. And so that's been my best way of generating my name. And then it's hopefully a flow-on effect. People know you from that, but then you do good work. So it's just keeps building and self-fulfilling thing after that. Just focus. Now I'm at the point where I'm just focused on doing good work, so to speak, and
it'll talk for itself.
Yes. Yep.
Yeah, because even I met you through a surgeon who did surgery on me, and I was just chatting to him one day, and I said, I need a knee guy.
Yep.
And straight away he was like, you're all in sports, aren't you? I said, yep. He said, Michael Dan, hands down.
Yeah.
And then, that's how I met you.
Yeah, that's very nice. There are plenty of good surgeons, though.
Yeah.
Yeah. But I do my best to do the best I can.
So I suppose the last bit, is there anything else you want to use? Imagine this part's not recorded.
Yeah.
Is there any useful information? Is there anything that you could script into something small we can throw on LinkedIn for you? Is there anything that this is what I'm doing now, this is my passion project, keep looking? Because that's the beauty of this place. We can just crop it up however you like.
Not necessarily, I guess.
Or what do you say to those that are thinking of getting into your line of work, that are at that pivotal age where they're not sure if they could get through? How many years of study?
I started medical school in 2006, and then I finished my fellowship at Leon Knee School at the end of 2023. So, and I did a master's and PhD throughout that. So, I don't know what you want to add that. University, over 10 years, over a decade of university, plus apprenticeships. It's a long time. Yep.
How'd you stay focused? Is it just focusing on the reasons why?
You don't stay focused the whole time. I guess like anyone in life, you have periods where you're not at the best of your game. But yeah, like those things we talked about earlier, I really do try to focus now on having a well-balanced life, making sure that, I get my me time. And for me, that's exercise and time with friends. And then making sure, simple things, making sure you eat well, sleep well, so you sound mind, and having someone you can debrief with when things don't go perfectly, So a burden shared is a burden halved or something along those lines. So that's really important for me to try to get me at the top of my game, so to speak. But yeah, I love, I had some high school students with me last year wanting to do work experience before, with that idea of then going into medicine, which was really cool. I have medical students do research with me, and I have trainees reach out to me for research as well. So I welcome anyone's inquiry or happy to help guide. I had a lot of good mentors and people guide me along the way. So if I can do the same to anyone else, then be a privilege, so to speak.
Awesome.
Yeah.
That's really good advice. I actually heard that. Familiar with Mark Boris at all?
Yeah.
Yeah. He's
The Apprentice.
yes, that's him. He's got this really big philosophy on treat the body like an athlete
Okay.
if you're in business. And that's
Yeah.
the best way to stay at top of your game all the time, which
Yeah.
you've kind of just said exactly that almost.
Yeah. Came to it from my own way, but I think it's a common approach by a lot of people to life. But yeah, keep enjoying what you're doing and look after your mind and your body. I think that's the best way to perform well.
Sweet.
Perfect.
Done.
Thanks for having me.
Thank you for coming along.
Yeah.